Hello everybody. Today we are going to discuss the case of this acute liver failure who presented to us with upper GI bleed. So our patient was 63-year-old male patient who was a known case of decompensated liver disease since 2018. He came with chief complaint of hematemesis and melena since 1 week and increase in frequency since yesterday. That is 1 day. So altered mental status were present since 1 day, and when he presented to us, he was in the there was a massive upper GI bleed was present. So we have intubated him in view of this massive GI bleed and altered mental status. So then we have sent his lab investigation. In that, HB came out to be 4.3. Fibrinogen was low, that was 117. INR was raised, that was 2.77. So patient was transfused with blood, 10 cryoprecipitate, 6 PRBC, and we have started him on terlipressin and albumin. Inotropic support was started in view of hypotension in the form of NORAD at 6 ml per hour. So, in treatment, we have started him on injection Piptas 2.25 gram, injection vitamin K 10 mg, injection soda bicarbonate, then injection terlipressin, which was going on in the form of infusion, and injection and fentanyl infusion. So this was the investigation of this patient. As I have mentioned before, HB was very, very low. That was 4.3. Platelet counts were low. That was 1,27,000. And the creat was slightly elevated. That was 1.6. And the SGOT, SGPT were deranged. INR was 2.7. So next plan was to take triphasic CT of this patient to know the status of portal vein. This was the triphasic CT of the patient. So triphasic CT showed narrowing of the portal vein and the thrombosis in the splenic vein and portal. So our further plan was this patient to go for TIPS or BAR2. So we'll discuss briefly how are we supposed to manage this upper GI bleed and what are the current approaches in the treatment of the gastric varices. So the gastroesophageal varices occur in approximately 50% of patients with liver cirrhosis. Gastric varices are the dilated collateral blood vessels that develop as a complication of portal hypertension. The best known and the main cause of portal hypertension is liver cirrhosis, and there is increase in resistance through hepatic sinusoids. So gastric varices are less common than esophageal varices, and bleeding from gastric varices represents 10 to 30% of gastroesophageal bleeding. However, 35 to 90% of patients with gastric variceal bleed experience rebleed, and this gastric variceal bleeding tend to be more severe with higher mortality. So mortality and morbidity rate vary between 30 to 50% depending on the severity of underlying condition, variceal size, and presence of sign that predict the bleeding. The more aggressive intervention, such as evaluation of liver transplantation or transjugular intrahepatic portosystemic shunt, can cause high mortality and morbidity risk. So the gastric varices, according to Serin, were classified as gastroesophageal isolated gastric varices based on the relationship with the esophageal varices and the location in the stomach. So type 1 gastroesophageal varices is located in the lesser curvature. Type 2 gastroesophageal varices is located in the fundus and continue along the greater curvature. So type 1 isolated gastric varices exist into the gastric fundus and they do not extend into the esophagus as well as in the cardia. So type 2 isolated gastric varices defined as ectopic variation that occur in the other part of stomach. So this picture is showing the different locations of gastroesophageal varices as well as isolated gastric varices and the treatment approach which we are seeing in the next upcoming slides. So gastroesophageal varices and the gastroesophageal varices share the same anatomy, pathophysiology, and blood supply. They usually receive the blood from left gastric vein and lamina propria. Isolated gastric varices, on the other hand, stem from the underneath lamina propria in the submucosa and are found usually in the fundus. Their blood comes from the short and the posterior gastric vein. Isolated gastric varices frequently present with the large gastrorenal shunt. Therefore, localization of the gastric varices is the important factor when deciding on treatment. Now, the treatment, there are some therapeutic guidelines such as American Association for the Study of Liver Disease, the Benevo Consensus Workshop, and the NICE guidelines. Based on the anatomical sites and location, treatment is categorized into two broad groups, that is endoscopic and radiological treatment. Surgical treatment is used less frequently. So, what is this endoscopic treatment? So, the gastric variceal sclerotherapy, gastric variceal band ligation, glue application with the variceal occlusion, endoscopic ultrasound guided coil and glue application, thrombin application, or combination is used in this. And radiological treatment includes mainly transjugular intrahepatic photosystemic shunt and balloon retrograde transvenous occlusion. So, endoscopic treatment includes sclerotherapy, band ligation, cyanoacrylate injection, or their combination. And in acute gastric variceal bleeding, endoscopy can be planned following initial resuscitation. Like first, we have to stabilize the patient. We have to start the bridge therapy like terlipressin, then antibiotic therapy, and then endoscopy is performed to identify whether the bleeding site is the fundus or gastroesophageal junction. So, glue treatment. So, generally, glue treatment is recommended for fundal variceal bleed, while glue or band ligation is recommended for bleeding at gastroesophageal junction. Once gastric variceal bleed is controlled, variceal scans are performed at certain intervals. So band ligation is now preferred over sclerotherapy in gastroesophageal variceal type 1 and is not recommended in isolated gastric varices because these varices occur in fundus, greater curvature and submucosa. If the varices and the contralateral wall cannot be captured in band ligation, blood flow remains uninterrupted and may lead to massive bleeding. So the standard treatment for isolated gastric varices worldwide is to administer sclerotizing substances in the form of glue injection. Once the glue is injected, it polymerizes within the varix and it forms a heart and form structure. If variceal bleeding cannot be controlled, then balloon tamponade, a TIPS, surgical shunt, or liver transplantation is scheduled. However, there is 15 to 20% risk of rebleeding during the first 5 days, even if optimal treatment was given. Gastric variceal sclerotherapy yields the greater success in the esophageal varices, but is less efficient into the gastric varices. More sclerosing substances is required if as varices is larger. Also, more sclerosant is used for sclerotherapy, particularly in gastroesophageal varices 2 and isolated gastric varices 1 compared to the gastroesophageal varices type 1. So, this fever, then retrosternal abdominal pain, and widespread ulcerations may occur as a complication due to the procedure. Serious complications include perforation, mediastinitis, may also develop and lead to mortality in about 50% of the cases. Gastric variceal band ligation is not the initial medical treatment of choice in gastric variceal bleeding. Risk of rebleeding is quite high due to supplying vessels. Repeat endoscopy and endoscopic variceal ligation should be performed in 1 to 2 week interval and monitoring should be maintained unless the varices shrinks completely. The EVL and injection sclerotherapy may also be used in combination. Now we'll see what is thrombin treatment. Thrombin treatment functions by catalyzing the conversion of fibrinogen to fibrin and supporting coagulation. It also has effect on platelet. It is an alternative for cyanoacrylate given the fewer complication and side. Generally, 1 ml of thrombin is injected into the varices. 5 ml of thrombin solution is potent enough to coagulate 1 liter of blood in less than 60 seconds. Thrombin treatment is very beneficial in difficult to treat gastroesophageal varices type 2. Now, what is this cyanoacrylate glue treatment? The cyanoacrylate glue treatment uses N-butyl 2-cyanoacrylate. Following administration, cyanoacrylate is polymerized and exerts its effect instantly within 20 seconds. The fatty contrast agent in the lipidal ultrafluid is used to avoid occlusion in endoscopy channel during the procedure. It is recommended to use 50-50% mixture of cyanoacrylate and the lipoidal solution. Treatment with this approach is also reduces the risk of embolization. There are some risks and potential complications associated with the cyanoacrylate injection. For example, pulmonary embolism, acute renal damage, splenic portal vein thrombosis, which may occur. Cyanoacrylate may less frequently lead to gastric ulcer, major gastric varices bleeding, mesenteric hematoma, chemoperitoneum, bacterial peritonitis, and etc. So the antibiotic treatment may therefore be initiated whether this is deemed necessary. Now this uh, endoscopic ultrasound guided glue and coil treatment are administered successfully and are safely. Varices are observed clearly by performing color Doppler endoscopic guided ultrasound prior to the treatment. Lumen is filled with water for better visualization of the gastric fundal varices, and EOS should be used in anterograde fashion. Now we'll see what is hemospray. Hemospray application is the procedure performed using hemospray devices. Hemospray, unlike traditional therapies, is non-thermal, non-traumatic, non-contact therapeutic modality that does not require the precise targeting of other endoscopic devices. It is used with success, especially in patients who received glue, cyanoacrylate treatment, and suffered from bleeding. Now we'll see what are the radiological treatments for treating variceal bleed. So it includes the transesophageal, transjugular intrahepatic portosystemic shunt, that is TIPS, and Barto, or combination of both. Transjugular intrahepatic portosystemic shunt or TIPS is the procedure that creates the shunt between portal vein and hepatic venous system via jugular venous way, placing shunt into the liver parenchyma at interventional radiology department. TIPS reduces the esophageal variceal bleed, treat the complication with liver cirrhosis such as refractory ascites. For TIPS, access is gained via transjugular vein when metal-coated expandable stent is inserted into the liver with the vein hepatica and end branch and portal end branch. Thus, the portal pressure is reduced, which leads to the reduced variceal pressure and therefore reduced bleeding. Now, this is the picture of the TIPS application. We can see the expandable stent is present in between hepatic vein and portal. Now, what is Barto? Barto is balloon occluded retrograde transvenous obliteration. It is a very popular modality used in Asian countries. So, the gastric varices are associated with the gastrorenal shunt in 60% to 85% of cases. And the flow in gastrorenal shunt, it flows in the gastrorenal shunt into systemic circulation. So the Barto is endovascular technique used as an adjunctive or therapeutic alternative to TIPS for treatment of gastric varices. So the radiologist first they block this gastrorenal shunt using balloon method in interventional radiology, which is followed by the intravenous application of sclerosing substances. So Barto achieved success in 76.9 to 100% of cases in acute gastric varices, and the likelihood of rebleed is low with 0 to 40%. Barto is as successful as TIPS without increasing hepatic encephalopathy potential. We recommended reviewing computed tomography or magnetic resonance imaging prior to the procedure to determine the approach that provides the best angle and to decide on the shunt. The sclerosing substance used for the Barto are ethylamyl oleate, then polydocanol sodium, tetradeacylate sulfate foam, and polydocanol foam. So ethanol amine oleate was described as the primary sclerosing agent substances used in this procedure. Barto is used in interventional radiology, and the right femoral vein approach was preferred in most reported cases. However, some centers have adopted only jugular vein approach. Catheterization of the gastrorenal shunt via left renal vein can be achieved using catheter using occlusion balloon. For portal venous shunt, Barto and the cyanoacrylate are safe, but there is a high risk of rebleeding. Portal pressure elevates following Barto, and it leads to the worsening of esophageal variceal pressure. Other significant complications that may include hemoglobinuria, abdominal pain, fever, and the pleural effusion. Shock and the atrial fibrillation are the major complications. This is the picture showing the different modalities of the treatment that is used into the gastric varices. Thank you.